So, just think globally about differences between the pediatric and adult healthcare systems, and these are presumptions, and these are crude, and these aren't always accurate, but in the pediatric healthcare system, we presume typically that a child lives with his or her family, and that the physician is working with the child and the family to provide health care. And we have the presumption that a child is, as they mature developmentally, is gradually learning about how to manage their own health and health care. Versus the adult system, where often it's individually based, not family based. The presumption is that the adult already has the skill to self-manage their health and to negotiate the healthcare system, and only in the case of new diagnoses and new conditions is there a need for acquiring new knowledge and skills. And so, these are crude kind of generalizations, but I think are relevant here in terms of negotiating the healthcare transition. Okay, so conditions that used to be associated with very limited life expectancy, often beginning and ending in childhood, are now associated with much more lengthy life expectancy long into adulthood. These data are actually from a study in that was published a number of years ago. So some of these statistics actually are still are no longer accurate. The average life expectancy of people with Down syndrome is now closer to the low 60s. And so it's been a whole different paradigm shift in terms of looking at many of these significant childhood diseases as ones of childhood onset, but extending well and sometimes late into adulthood. So healthcare transition, what we're talking about tonight, is the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented healthcare systems. And healthcare transition is a process. It's not a single event. And the transition process begins long before the actual transfer of care to an adult health provider. What, to a great extent, molds the transition process is where is the medical home or the site of most health care occurring prior to transition. So I listed some examples of chronic conditions, childhood onset, that require healthcare transition, but are ones that involve high involvement of specialty health care. So, for example, for individuals with congenital heart disease, children with congenital heart disease, they may receive most of their health care from the cardiologist's office, not the pediatrician or family physicians. Similarly, children born or acquiring HIV may spend most of their time in the infectious disease specialist's office. Those with sickle cell in the hematologist's office, those with type 1 diabetes in the endocrinologist's office, those with cystic fibrosis in the pulmonologist's office, those with juvenile arthritis in the rheumatologist's office, and those with epilepsy in the neurologist's office. Whereas many children with developmental disabilities and associated diagnoses that I've listed here still are spending the majority of their time and receive most of their health care in the pediatrician's office. So, and of course you have children who have comorbid conditions, so children with cerebral palsy who also have epilepsy, who receive most of their health care in the neurologist's office. And so where children are receiving the bulk of their health care can influence how the transition process goes and what is needed to be considered as you're planning and implementing transition. So, one way of looking at different models of the medical home would be, as listed here, conditions in which the generalist will be serving as the primary manager of healthcare with perhaps occasional specialty consultation would be, say, children with asthma who are transitioning to adult care, children with ADHD, children, adolescents with Down syndrome, versus other childhood onset conditions will be associated with an adult medical home in which there's co-management of the condition between the primary care adult physician and the specialty adult physician. So examples of these conditions might be, again, adolescents and young adults with some congenital heart diseases, type 1 diabetes, HIV, or autism. And then finally, there are some adolescents and young adults whose conditions often lead to transition whereby the subspecialist, the adult subspecialist, provides the bulk of health care, and then there are far fewer health care encounters with the primary care physician. So examples might be some adolescents or adults with cerebral palsy, spina bifida, sickle cell, or intractable epilepsy. So as you're planning transition, kind of think about which of those three models likely applies to you or your family member. You know, will the bulk of your adult health care be with a primary care physician, a family physician, an internist, or an internal medicine / pediatrician? Will it be where you're going to be, as an adult, getting health care from both kind of groups, specialty and primary care? Or are you or your family member going to be transitioning to adult health care system whereby the subspecialist will be the primary provider of healthcare services? And probably the most common example I see of that is a person with intractable epilepsy who spends a lot of time going to the neurologist. Okay. This, you know, the different agencies and governmental groups and groups funded by the government have looked at the whole issue of collaboration between primary and specialty care for children and youth with special health care needs, and have looked at this transition process. So provided a document, you know, so for people who want to look at this type of literature and look at the background. Okay. So as we talk about healthcare transitions, you know, this of course is in the context of a whole bunch of other transitions that are happening in the lives of adolescents and young adults with a special healthcare need. So, and I know that Family to Family Ohio, and this transition boot camp has addressed a lot of these other domains. So actually I included some slides, and Amy had me delete them, that relate to, financial things, or transitions relating to education and vocation, and things relating to legal issues. So, of course, healthcare transitions occur in the context of a whole bunch of other transitions that are, vitally important in the lives of people with special healthcare needs. And so, things that, or kind of factors that mold or affect healthcare transition are kind of listed here. So what affects transition-related health at the level of the adolescent individual include, of course, things like developmental level, how they learn, their motor skills, their mental health. Of course, that all needs to be considered as you're working to try to optimize and maximize self-management of healthcare entering adulthood. The healthcare transition is affected, of course, by the pool of healthcare providers that are available to accept care, their knowledge, whether there's institutional support for adult healthcare providers to accept the care of complex individuals, financial and insurance issues. And we see similarly factors that need to be considered in the domains of family, school, and community.